Health and Human Services Oversight Committee for September 22, 2023. And would the clerk please call the roll? We have pending a special appointment of Dr. Palmer to be an alternate, and then you will come up to be a regular member for today only, because we have a few things we have to vote on, and you make the quorum. Anybody who leaves will be punished. Okay. Would the clerk please call the roll?
Representative Pearson.
Here.
Representative McDonald. Representative Weber. Representative Edwards. Representative King here. Representative Merchant. Representative Murphy.
Here.
I always do this. Senator Rosenwald. Senator Gray.
Present.
And Senator Avard.
Thank you. We will defer things needing a vote until I hear back from the Speaker's office. You've been specially appointed. Any other alternates is also brought up to being voting members today to make a quorum. DHHS Commissioners update from my fellow. We were both on a Millbank Fellowship together, so we are fellows. And introduce yourself, not that I've forgotten, but.
Yes, good morning. Marissa Hann, Associate Commissioner at DHHS. And Commissioner Weaver sends her regards. She actually is a Millbank Fellow this year, and they had their first gathering in Utah presently. So she is there, but listening in and sends her best. So, and actually before I start, there was someone else I wanted to introduce or perhaps reintroduce, and that is Krista Morris, who's going to wave. Krista is our new Director of Intergovernmental Affairs. She started a few weeks ago. She is back home in New Hampshire, having previously worked at the Division for Public Health Services as their legislative liaison, and we're very lucky to have her back now helping support and work with you all and liaise with you all as we advance our common goals. That relate to health and human services. So you'll be seeing more of Krista, but just wanted to welcome her.
Which means her business cards aren't ready for distribution
I don't know. They're usually probably not quite ready.
If you can give me the vital information from my phone sometime before you, please. Thank you.
Yeah, great. So I think that, go ahead.
Means that someone else is no longer with us?
No, that is not the case. And in fact, is John here today? No, John Williams is continuing. This is just to broaden the reach of our supports. Krista's role will be engaging in the work and strategy, particularly as it relates to the interplay between state and federal activities. So, for example, helping us prepare presently for the possibility of a federal shutdown and what that means for HHS, what it means for the people we serve. So it's really just working hand in glove with John Williams as he continues to support all of us in our common state activities. So,
for the record, John Williams is at Lake Tahoe. He says it's for a family wedding. I think he's out visiting the Cartwrights.
All right, we'll take it.
It's a bonanza for him.
Great. No, thank you for asking that question, and we're grateful for John for his critical ongoing services as well. So I believe the topic that you wanted to hear a bit about today is an update on the Youth Development Center, YDC, and its closure and rebuild, which we did talk about 1 or 2 meetings ago. So I'll be brief and then answer any questions you have. But just as a reminder, it was during the last legislative session through HB 49 and SB 1 that the department was given the requirement to shut the current YDC, which is this new Youth Services Center in Manchester, and rebuild a facility for up to 18 youth. And to determine a location for that and to include a variety of other requirements listed in HB 49. We were also given funding to carry out these activities. And so over the last several months, we've brought on an architecture firm to support the pre-design, design process. We've engaged extensively with the community in ways I'll talk about, and we have completed site selection. So, as part of that, and I should note the site, as stated, I'm sure at the previous meeting, the site where the new facility will be located is on the same campus as Hampstead Hospital and Residential Treatment Facility, which is now under state ownership as of about 16 months ago. And so we have begun work on that campus with the architects planning for this future home-like, architecturally secure facility to be moved there. So where we find ourselves in the process is what we call basically pre-design moving into schematic design. I've learned a lot of architecture and engineering terminology in the last month or so, but fortunately, we're really working with the best of the best when it comes to HDR, the architects who are engaging in this project. They have 30 years of experience building juvenile facilities across the country, state-of-the-art, architecturally secure, but also very appropriate to the therapeutic needs of this complex population. So they have been working to determine all of the square footage needs, what needs to go where to ensure that that this is a highly secure facility, to ensure that this is a facility with the programming, residential, clinical components that it needs to be highly successful. The next phase is called schematic design, which is where they get all the fancy blueprints and design documents prepared. All of that is in preparation for the eventual transition into a construction phase, for which we'll be doing a competitive procurement for a construction firm. That bidding will take place next year. And then beginning pretty much exactly a year from now is when construction would actually begin. We expect that to be about an 18-month period. And that would prepare us to begin the transition of youth into the new facility at the end of 2025. So it's a appropriate, but also I'd say aggressive timeline. We need it to be in order to spend the federal ARPA dollars that are dedicated to this effort. And we're feeling grateful. I think what has transpired since our last meeting is that the architects, the HDR, have been much more hands-on in terms of being on that Hampstead site, neighbors to right, probably basically abutting Representative Pearson's own property, and beginning to scope out all of the needs. How do we design and build a building that meets the needs, but also is highly respectful of the land that it sits on, of the water, of the desires, concerns, needs of neighbors and community members. And that is the last thing I want to comment on, which is the extensive community consultation that has been going on. Senator Birdsell has been convening a very active and energized YDC Impact Commission. I think we're on our 5th meeting. And that is a group made up of different individuals, including ourselves, with involvement in this project, as well as law enforcement, state police, Hampstead police, fire. And the goal of that commission is to really understand what are the various impacts of this new facility on the surrounding community, and how do we mitigate any negative impacts, whether that's traffic, whether that's concerns about safety or any issues around that, the architectural design, the aesthetic look of it from the street, et cetera. And so that's been a very active group. And in addition to that YDC Impact Commission, which is obviously open to the public, and it includes a subcommittee on safety, we've also had begun a series of community forums in the town of Hampstead. And that's an opportunity for the town to weigh in on what their concerns are, what their feedback is. Those have been lively, as you can imagine, but also very helpful for hearing what the concerns are, what the myths are, what the areas that we need to hear. Not surprisingly, there are folks who have concerns. They have concerns about what this means. Is it possible for youth to run away from the future YDC facility? The answer to that question, by the way, is an absolute no when it comes to YDC. This is a state-of-the-art facility, and just as no youth has ever eloped from SYSC in Manchester, that will be the case with the future build, which is even more secure. Many of the concerns from our perspective, and Representative Pearson, you were at our last meeting, so you may have your own reflections. Many of them are coming at an interesting time where Hampstead Hospital is going through some growing pains to accommodate a more acute population. So again, we had this YDC facility entering the campus. We have Hampstead Hospital and residential treatment facility on that campus, now under state ownership, serving a very acute population. And there are some challenges that we've faced in terms of, even though we have all of the appropriate staffing ratios, even though we have strong contract oversight, we've had to make some important adjustments adjustments to ensure that that facility has the stability that it needs. It has required some significant partnership with local law enforcement, fire, EMS, when things have happened. We're proud that thanks to many of the changes that have been made in terms of the physical facility locking, in terms of fences that are going up, et cetera, we really haven't had the issues of youth from the hospital running away that we had for a period of about 6 or so weeks. Those were all fortunately without incident in terms of any consequences. We were able to round the kids up and bring them back where they needed to be. But we have now basically prevented that from happening again at the hospital. And as I said before, it will absolutely not happen at YDC because of the nature of that facility being so much more secure. We've also engaged in a number of different leadership changes and programmatic inventory of all of our safety strategies to ensure that Hampstead Hospital is not just preventing kids from running away, but fundamentally managing very acute escalated behaviors within the facility appropriately. And so obviously we have more work to do, but we're feeling very optimistic about stabilizing what needs to be stabilized on the hospital campus, and I think that in turn will reassure the community of just how important it is for us to be good neighbors on this growing campus as YDC makes its move there. So I will. There was one more thing I wanted to mention, and it's escaping me at the moment. I had one more thing, which is we also have a YDC steering committee. So this is basically a group of people who are working side by side with us as Department of Health and Human Services, our child advocate, et cetera, to design this physical facility. And Representative Pearson has kindly agreed to serve on that, as has the town planning board chair from the town. So essentially what we're trying to do is bring in as much town voice and town input into the both detailed and higher level planning for that facility so that we can ensure that it's collaborative all throughout. So I'll pause there.
My response would be, while the meeting was unfolding, I was more than impressed with how Senator Birdsall and Associate Commissioner Henn kept the lid on. I mean, I had 911 on my phone about ready to push the final one several times during the meeting. I don't know how you did it, but you kept the lid on. Also, I am not an architect, but my son-in-law is. And so we discussed how it could be secure without looking like, so that the people involved would feel this is a comforting, welcoming, and helping facility, and the residents who all live further away from it than I do would know it's secure. And I think the architectural team we have is doing a very good job. Any further questions or comments? Yes, Representative Murphy.
Thank you. You mentioned they were interesting. I'm just kind of wondering if you could elaborate on what their major concerns were in the forum.
Sure. Yeah, so the community forum concerns, I'd say, I think we drilled them down to 3 areas. We'll see if I can remember. I mean, the first thing that and this is not just at this community forum meeting, it was at the prior one. We had one at the Hampstead Public Library that was maybe a little less lively, and then the one that Representative Pearson's describing was held at St. Christopher's Church. Across the street from the current campus, which despite being a house of worship, proved to bring about some strong opinions and feelings as well. But it was all, as Representative Pearson said, I think we managed and helped people feel heard. So the first thing we heard is that this is a community that really cares about vulnerable people. Because of that, there were comments made both about the importance of the services delivered by DHHS, but also concerns about elderly individuals who live alone at the retirement community across the street, and kids who are used to having, not locking their doors on some of the beautiful abutting properties. And so I think we tried to focus people on how that same value of supporting families and keeping our families safe and supported is embedded in what these DHHS facilities are looking to do. So that was the first element. The second was around really land concerns. We've heard we have some very expert neighbors neighbors who have concerns about water, who have concerns about the everything about the topography of the landscape and the snow plows. And they have sent us at times even 17 pages of detailed analysis, which has been very helpful because it allows the Division for Public Works, which is our partner at the Department of Administrative Services, to be able to ensure we're checking all the boxes when it comes to engineering solutions, when it comes to the various assessments and things we have to do. And we take that seriously. We don't have to, as a state, go through all of the approvals that a, say, private or commercial property would, but we are going to go before the town planning and so forth to ensure that they're having the input that they need so that we show that we're developing responsibly. So I'd say the first were around kind of land, water, aesthetic, and privacy concerns. Third was around safety, which I think I've talked about, just this kind of perception, which I think we were able to mostly assuage, that kids are going to be running amok everywhere and that it's a danger, which we firmly believe it's not, but we also have more work to do to be able to stabilize things at the hospital to prove that. And then I think the last area of concern was around staffing. How are you going to attract the staff to be at this facility, to work there when you're already having challenges at the current Hampstead Hospital, which is a great question and point. And we have a number of different strategies going on, both within our human resources team to ensure that we're planning for that, but also I think part of what is proving effective, even though some people who work at SYSC aren't interested in kind of making the move, many are actually very excited. They're going to get to work at a facility that is state of the art, that is a beautiful place to work, that is secure, and yet any of us would the amount of light that's going to be flowing in, the quality of the physical layout, and then the corresponding impact that has on the people we serve who are positively impacted by that design is proving to be highly engaging to many of the staff who want to work in there and who want to move over with us. So I think
Did they mention the good neighbors?
and great neighbors, who including great neighbors' dogs, more importantly, who sometimes wander onto our property. So so we're feeling optimistic, but and we're also trying to one of the things we're emphasizing with the community is how much we're hearing them and then the specific adaptations and changes we're making based on that feedback.
Yes, follow up.
Just follow up.
Yeah.
Thank you for that. Is there a name for this facility, or are they going to name it separately from the Hampstead Hospital, or how is that going to work out?
Yeah, that question has come up a little bit. We haven't figured that out yet. In statute, it is referred to as the Youth Development Center, YDC. But if anyone has ideas or creative suggestions, I believe Representative Pearson actually suggested we work with local school children to kind of get their help around design, around naming, around some of the aesthetics, which I think is kind of a nice idea as well, so that we create a sense of not just community tolerance, but community pride in this building.
Is Director Fleischer planning on being here today?
So Children's Oversight overlapped today with HHS Oversight. So you can talk to Senator Carson about that. But because of his being on the agenda over there, I told him we'd tag team.
Okay.
But he may wander
Anything
in.
else? Yeah, I have some stuff for him.
Okay.
Anybody else? Anything else you wish to present?
Nope. Thanks.
Thank you. Media Power Youth Organization and Mission Overview. And you can always bring up a third chair. Miss Tilly, if you want. No, you're good? You're good? You got good people working for you, yeah. Okay.
Hello, thank you for having me. My name is Heather Inyart. I am the Executive Director of Media Power Youth, and we are a youth development organization dedicated to helping youth build healthy communication skills through media literacy. And we have been working in the state of New Hampshire for over 2 decades. We actually started as a community health clinic by a group of physicians and concerned parents who were really looking at the impact of media on the health and well-being of children. And we work on a variety of prevention initiatives here with different types of organizations, such as the Partnership for Drug-Free NH and local YMCAs, Boys and Girls Clubs, and schools. Before I jump into...
Just introduce your neighbor.
Hi there, I'm Jenny O'Higgins. I'm a senior policy analyst for behavioral health with DHHS.
Good.
Thank you. Before I jump in too much, I'd like to spend a little time talking about how we define media, because we look at it very broadly. It's a system of communication and includes TV, entertainment like video games, as also movies, as well as tools that our youth are using every day in the classroom, like Google Classroom, where students are using it to complete assignments and talk with their teachers, is actually a form of social media. And we want to help our kids learn how to navigate these spaces for their academic learning and their success in school and out of school. When we talk about the mission of our organization, we do recognize that media can have negative effects, but we intentionally frame our mission in a very positive way. Our mission is to inspire young people to engage with media in thoughtful and creative ways that support their physical and mental well-being. And it's always about well-being for us, but we want to approach when we introduce ourselves to people to show that this is going to be a start of a conversation and that we're not approaching it from a place of judgment. We have 3 buckets of service: youth programs, which I mentioned, which I'll talk about today, family educational opportunities that include parent nights at schools, and also curricula that other resources that we provide to local teachers across the state. When we consider our impact, our first goal is to help people understand what is this connection between media and the culture of our community, our health and relationships. These are protective factors that enable us to be resilient in the face of change. And we provide opportunities to build communication and critical thinking skills, as well as to understand what are those media habits that contribute to well-being and which ones are not contributing to well-being. And we provide resources to a lot of youth serving organizations, just parent guides and curricula. We are very fortunate to have a number of research partners and that help us in this work. We have a longstanding relationship with the Digital Wellness Lab at Boston Children's Hospital, with the University of New Hampshire, the Granite United Way. We also more recently have been working with the University of Wisconsin's Department of Pediatrics on a program around teen and adolescent mental health. And that study was published in the JMIR Mental Health. When we think about media literacy, the foundation of all media literacy is critical thinking skills for youth. So what are the skills that they need to make healthy decisions in their lives? And so I'm on actually slide 6 that talks about some of these skills. And what we hope is in an article like this People Magazine, that our youth, when they are reading this kind of material, can recognize this is actually an ad from influencers that are tapping into something culturally to show that to try to make the case that using alcohol would be part of a healthy lifestyle. And what media literacy teaches youth is to question this premise and to learn more so that they can make a healthy decision. The role of youth voice is very important to our organization, and we have a youth advisory board that meets monthly that informs the work that we do. They share their lived experience, and we build programs off of that. It actually started with a group of New Hampshire students called our Youth Design Team, where they worked with us over the pandemic to design a curriculum, which I'm going to talk about. And it's their input in developing this resource. And it was such a positive experience for our students. And they developed something that was pretty significant, as you'll see. And we decided to continue that experience and make our Youth Advisory Board a permanent part of how we work. In social media, it's really the infrastructure that our youth are using to create communities. And these are very interactive spaces, and they are how they're building relationships. And right now, we often see that that's compromising their mental health in a number of different ways. We talk about social comparison, social rejection, fear of missing out. These are all aspects of social media that our youth are experiencing it, which is compromising their mental health. However, there's also a lot of aspects of social media that contribute to well-being in terms of social connection and belonging. And so we consider our role at Media Power Youth is teaching youth how to balance these things and how can we ensure that the behaviors and habits that they're developing around this part of everyday life is actually contributing to their well-being. We have a number of different resources and programs. Here is just a sample of all of the programs in our portfolio. We do have a lot of parent programming that we do, including a service called Digital Wellness for Families, where families can actually come together and discuss their own values and what type of healthy media habits they want to create at home. And so our programs are really driven by the participants themselves, and we deliberately structure them that way. I did include in the presentation a few pictures of some of our different programs that our kids are learning through hands-on experience. And the research shows that when students are creating media about something that's important to them, it causes them to really consider what are their own media habits and to use media in ways that are more beneficial for their well-being and the well-being of their community. An example of our work is during the pandemic, we worked with Girls Inc. on a music video project, which was really meant to destigmatize asking for help. When you talk with youth, a lot of them are concerned, not only can they sometimes have trouble identifying who a trusted adult is, but they don't often, many of them don't necessarily believe that if they ask their help, they'd get it. And so the purpose of this music video project was to show them that asking for help would be a sign of strength and not a weakness. So they could encourage their peers to seek out help throughout the pandemic. And our parent programming is also very interactive, and we provide opportunities for parents to actually practice talking about media with their kids. And so they can develop the language and the vocabulary to better understand what quality screen time looks like, and so that they have the tools to address some of these influences at home. We do have a wide portfolio that teachers here in New Hampshire can utilize to teach these skills. They range from 4th grade up through 9th grade. We're also working on some lessons for younger grades, and they're really based on a unique set of needs based on that student's relationship at that life stage and where they are in terms of their adolescent development. They're designed to be really flexible so that teachers can use them in a variety of settings to teach our kids these critical thinking skills that they need. One research that I want to highlight is around our curriculum that was initially called Digital EQ and Mental Health. This is the one that was developed by New Hampshire students, and it has been renamed by the students and teachers who we piloted this curriculum with as Digital Climate Change. And it was all around one single driving question, which was what would middle school students need to learn and know in order to build a safe and supportive network. So in this curriculum is a project-based learning module, and the students look at how to recognize and build empathy skills in digital spaces. And so this is an important tool in school climate initiatives, and also really empowers students to think about how they're using these tools and how it's affecting their relationships in their lives, which you know is a protective factor. They learn some foundational skills around emotional intelligence and how to recognize miscommunication, how to navigate conflict. And then they produce a book, a guidebook for their peers at their school on how to use social media positively. And this doesn't necessarily have to be a public platform like we're not advocating that they teach each other how to use Snapchat. This can be how do we use Google Classroom, a tool we use every day in our school in a positive way.
Ms. Inyat, because of the time and the schedule that we have, I'm going to now call on the committee, and Dr. Palmer, we grant you permission to speak, not vote. We're chasing down that. But if we have any questions for the presenters. while they're preparing that, on page 10 of your beautiful, wonderful handout, you really know media, which is good. The bottom slide, number 20, 18 states currently have media literacy policies, and I do not see New Hampshire as one of them. Is this in the works?
I think we're having a lot of conversations right now about that with the governor's executive order on social media and mental health. While I say that we don't have a specific legislative policy, there's a lot of good work being done in our schools around media literacy and teaching skills, both in schools and after school settings, as a result of the curriculum that we've made available. We do a lot of teacher training, and so I would say there's a lot of activity happening, although we don't necessarily have a formalized policy around media literacy.
But as you evaluate what is going on in numbers of schools, different laboratories of testing this, we suspect that there will be a policy initiative forthcoming. Would that be something the department would come up with, or would that be presented to some legislators, perhaps for a bill filing?
So I think this is the partnership where when DHHS came to speak about social media and mental health, we're now bringing in Media Power to talk more specifically about media literacy and that piece of the education, because this is so new, really, that we're continuing to learn and research and understand what are the connections between mental wellness and media literacy. It's this partnership to try to figure out how we do this work together that we're still in, and understanding the policies that have been passed throughout these other states, whether or not they have unintended negative consequences or where they're truly helpful, and learning from that to frame up what does New Hampshire need. I think already we're doing a lot to close gaps from symptoms to treatment for our young people, and make sure that we have mental health education, social emotional learning, access to counselors and social workers in our schools, appropriate screening and intervention to kind of get and stay on top of all of the mental health challenges. But it's the complexities between how is social media creating healthy, positive connection, and where is it creating negative impacts that we're still learning about.
New Hampshire has a reputation for being either first or last in just about everything. The danger with last is obvious. The danger with first is we're the ones who are making the mistakes to learn from them. So we do have 18 states who are doing that for us. And I'm sure that with what you're doing in the schools and what you're learning from these 18 states, pretty soon we'll have a policy that we can be proud of.
Absolutely.
That was a push question. Representative King.
First, I'd like to thank you for the report that you gave us in June, which was titled something similar, and I can't think of it right. Our group has actually renamed it Technology and the Impacts on Youth, and you gave us a lot of good data. And over the summer, we've gone and done even more research on this. And one of the questions back in June was, what are the solutions? Because it's always great to bring up a problem, and if you don't have any solutions. So here you come in September, and I see a lot of solutions here. So thank you for the report in June and the solutions now. Now my question is, from what I understand from this report, kids actually got involved. You did this. How did you actually do that?
Sure. So we had an application process for youth that we sent out for those that were concerned about media use and wanted to provide guidance to adults, teachers, to build programs that would address some of the challenges that they were experiencing. And then from that, we formed this advisory group. They were asked certain questions about their current relationship with media. And what's been really nice to see is that we have a pretty wide range of perspectives. So some who don't use social media at all for various reasons, its impact on their mental health, and some who are advocates and creators. And so we felt it was important to have that kind of diversity. And we meet monthly, and our schedule adapts to kind of what's going on with technology at the time and what their lived experience is.
Okay, great.
Follow up?
I'm sorry.
That's all right.
Thank you, Mr. Chairman. All right. So, and I'll have one other follow-up too, if I can.
Would you like to buy a book of 6?
As long as it's discounted. So do you have one single area, like a Boys and Girls Club, or is it some place, or did you go through the schools?
We work across the state, and so often schools will tell us if there has been, say, a lot of cyberbullying and they need help navigating it and they want to engage their community in that. So we have worked with a lot of after-school programs. Some schools, we're doing some professional development here in Concord in this fall. And then we will, so we'll basically work with many different types of organizations. And we always start with, what are you seeing, what do you need? And then how to match a program that's going to address that need.
Okay, thank you. And my final one?
Yes.
If I can,
You may.
and I may.
I think you can, but certainly you may.
The all-important one is the parents. And how are you seeing parent involvement? And then how did you actually reach the parents? This is one of the problems that we're seeing in our communities is a lot of parents that need this aren't coming forward. So how do we actually find the parents?
I will say this is ongoing because parents have a lot on their plates, and media can be stressful navigating this with our youth. So we will, there's a couple of different ways that have worked for us. So when we do a presentation, we'll often work to provide either food or have childcare, or sometimes we do family presentations. So they bring the whole family together to talk about this as part of like an after school night or an event. We've also started to do some online offerings so that parents can log in and do a virtual session from home. And we will continue to talk with parents and innovate in what we can do to try to provide these in a flexible way for them. We also have a standalone parent guide or that we'll distribute at various child-friendly events. We've started to do more festivals and fairs here in New Hampshire to be able to reach parents when they're out in the community and to start that conversation.
Thank you.
Any further? I think Representative Murphy, you had your hand up.
Yes, thank you. And thank you for this work. I mean, it's obvious that we see it personally and even, socially around various areas, the importance of social media and its impact. My question is, number one, is it fair to say that the primary mission is not so much the use and the creation and the mechanics of social media, like the hands-on projects, but more of a critical eye to its use, in its implications, in its impact on society and kids? Number one question. Number two, in reference to Chairman's question on slide on page 20, if people in other states, have this, in fact, I'm specifically thinking about Massachusetts, where is this type of policy, literacy policy, housed for like teachers to access it and understand it?
So let me address the first question on our mission. And yes, it is the technical skills, the media creation skills are is more the pathway. It's the topic area. We know youth are really excited and interested in talking about media. And so we harness that passion and interest to talk about this bigger picture. So them being critical thinkers when it comes to the information that they're presented with, and also to be healthy communicators. Can they express their needs to others in a positive way? And that translates both offline and also in digital spaces. That's the core of what we do. The media creation is just the innovation so that we're really engaging students. And we know from how kids learn that hands-on component really helps them to understand the material.
So it's the hook that gets them into the program.
Yes. In terms of your second question, this will, in some places, be housed within the Department of Education. So it might be credentialing and ensuring in continuing education that there is some media literacy training as part of that. Sometimes it's in providing guidance and standards. In other states, it's working with the local university system to ensure that as we're training the next generation of teachers, that media literacy is part of that foundational training that prepares them for teaching.
Thank you.
So just additionally, we can email the committee the policy report specific to media literacy, so you can see what policies have been implemented in these other states in more detail, many of which are educational standards around media literacy, but some are broader, like allowing for mental health days to be excused absences or increase access to counselors and treatment and screening in schools and things like that. But there are some that are very specific to media literacy, so we can make sure that you all have a copy of the national report.
And I will say that one of the foundations of our organization is that, yes, we do work a lot with schools, but now that we're all walking around with these cell phones, this is an environment that our children are in 24/7. And so looking at experiential learning in a variety of contexts, I think it'll be really important for the well-being of youth going forward.
Thank you for your presentation. Before I call the next group up, I have good news, bad news, and good news. The good news is I got a text 5 minutes ago from the Speaker's office. The bad news, it's from a different state. He's seeking money for a re-election campaign. I'm not kidding. The good news, however, is Representative Palmer, you are going to be replacing Vice Chairman McDonald, so welcome to the big children's table. Now you have a voice and a vote. And with that, I would like to go back and take a look at the minutes of the June. Was that?
Move to accept.
Do we have a second? Do we have any comments? Wonderful. All in favor?
Aye.
Opposed? Thank you. Second item I need a quorum for, which I now have, is we have the Alzheimer's disease and other related dementia subcommittee of this committee. Is Jessica Eskeland or Mackenzie Nicholson here?
Jessica Eskeland.
Come on up. And not only you know she's here, you know where she's here. Come on up.
Good morning.
Good morning. And this is just, if you want to say a few words, then
I am just continuing to track people down. We have almost everybody with updated appointments, letters reflected in the clerk's office and updated on the website. So I'm finalizing that. And I am meeting with Senator Avard hopefully next week to talk about next steps in terms of if he is appointed chair today.
you'd like to be meeting with him.
I'd like
One
to be.
thing we are doing, the chair suggests to the committee, we finally tracked it down, that the chairman doesn't make the appointment, the committee does at the chair's encouragement, and that no one else on the subcommittee may be the chair, only legislators. So I had a small group to pick from. I asked Senator Avard if he would be willing to serve. He said he would be. And so I would like to ask the committee for acceptance of Senator Avard as the chair of this special subcommittee.
So moved.
So moved. Second? In favor? Opposed? Thank you. Meet with Senator Avard next week. would
I
you?
will. Thank you very much.
Thank you. Now, next. Chair recognizes Melissa Hardy and Sandy Farrows to give an update on the DD and ABD waitlist quarter. This is your quarterly report.
Good morning.
Good morning.
I'm Sandy Farrows. I'm the Bureau Chief at the Bureau of Developmental Services, and Melissa Hardy is not with us today. She's
see
out of
that.
the office.
Yeah.
So I'm here to give an update on the quarterly
And it
waitlist.
looks like this.
Oh, yes,
for
it's the
everyone
pie
in
chart,
your
the
packet.
orange and blue pie chart.
Got it. Thank you.
That's an overview of some of the data points that I'll be presenting today. The quarterly waitlist report that I'm reporting for today is the quarter 4 report for fiscal year 23. So this covers April, May, and June of 2023. And in total, for the entire fiscal year, for the developmental disability waiver, we were able to allocate funding for 1,193 people. Broken down, that means that we had 282 people aging into services, we had 58 people that were new to services, and we had 854 people that already received services that were getting additional services. That totals 1,193. Of those people that were allocated funding, we had 54 people that were able to receive full or partial. And this is the pie chart that's in front of you. You will see that there were 54% that received full or partial, and 46% that were unable to receive services. for the fiscal year. So broken down, we had 644 people that received services, and 549 services did not begin for people. That was broken down into specific reasons that people were unable to start. And the top reason was that there was no reason. I'm sure you picked up on that. One of the challenges when we were pulling this data was that we were transitioning from an old system to a new system of reporting. So there were many blank spaces. And it's very safe to say that the majority of these people did not start services due to an inability for the agency to find a provider agency to offer the services, or the inability to hire staff to deliver the services within the organization. So as you can see, as we go through the reasons, we had 22% that no longer requested services. So they changed their mind and decided they didn't want services. And then staff and provider recruitment and selecting an agency were the next two issues that people ran into in starting their services. So that's the developmental disabilities waiver, which is adults with developmental disabilities. The next waiver is the in-home supports waiver, which is for children with developmental disabilities living at home with their parents. So for the entire fiscal year, we were able to allocate funding for 130 individuals. Broken down, we had 68 people that were new to services and 62 people that were already receiving services but getting enhancements. Of the 130 people, 77 were able to receive full or partial, and 23% of those services were delayed. So broken down again, we had issues running into staff and provider recruitment, and 13% of them just no longer requested services. So moving on from the in-home support waiver onto the acquired brain disorder waiver, which serves people with traumatic brain injury and acquired brain disorder. We have lower numbers for this waiver, totaling 61 people over the fiscal year that were allocated funding. 15 of the 61 were new to the services, and 46 needed enhanced services. Now, out of the 61 that received funding, 60 of those individuals were slated to begin services within the fiscal year. So out of those 60, we had 44 that received services and 16 that did not receive services, or their services did not begin. Again, challenges around provider recruitment. And for this population, we had a number of people that didn't have Medicaid established. So we would have to go and work with them around establishing their Medicaid eligibility. So those are our numbers for our 3 home and community-based care waivers within the developmental services system. We are working on trying to address the issues around identifying provider agencies and supporting agencies so that they can recruit staff to provide the services. We do understand that that is the biggest challenge across our service delivery system. Any questions?
Any questions? How aggressive is your recruitment? I know from my day job, I have openings too, and I'm just wondering, what are you doing more specifically to try to fill your gap?
So we have a very busy year ahead, and we just crossed the finish line for our corrective action plan to become compliant with federal requirements, which everybody is familiar with our BDS corrective action plan. Going into the next year, we're working hard to develop rates that are based on provider cost. And it's our intention to develop a rate that is going to meet the needs of our provider agencies and also incentivize direct support professionals and their professional growth around certification and training.
That is to say, you might take in some people who are almost there, but give them, as part of the package, the training to get there.
Yes, and incentivize providers to do the training for their staff so that they can improve recruitment and retention within their organizations.
Good. And thank you for your continued efforts to interface with the public. I know, as one who attends the Hampstead meetings about that which is in my backyard, it's difficult dealing with people and their needs, which are very personal and very real to them. But I want to thank you for your continuing efforts to reach out to those folks.
And thank you for your support as well. And that stakeholder engagement is a strong priority for us going into the next year.
Thank you.
Thank you.
And thank you for your presentation.
You're welcome.
Okay, we are now up to the New Hampshire Healthcare Quality and Patient Safety Commission Annual Report. And while I'm putting out brush fires, would you please introduce yourself?
Now I think you can hear me. Okay. Good morning, Chairman Pearson and committee members, and thank you so much for allowing us to present the 2023 annual report of the New Hampshire Quality and Patient Safety Commission. My name is Chris Herring, and I'm the Vice President of Quality Improvement at the Foundation for Healthy Communities, and I'm the administrator for the commission. And I'm joined by...
I'm Rory Dodds-Diamond. I am the director of the Center for Quality and Safety at Southern New Hampshire Health, and I'm the current chair of the commission.
I assume you all have copies of the report? Okay, great. Thank you. I had some available. So I'm going to just briefly educate you on the purpose and structure of the commission, and then Rory will get to the good stuff and give you the highlights of our work for the past year. So the commission was first legislated in 2005, and with the purpose of providing confidential protections for our New Hampshire hospitals to gather and to review adverse events experienced in their facilities, discuss root cause analyses, and develop best practices to improve patient safety. The commission was so successful that in 2019, it was legislated as a permanent commission. And in addition to our 26 acute care hospitals, 4 specialty hospitals and New Hampshire Hospital, ambulatory surgery centers were also invited to participate. We have a designee, the Commissioner of DHHS, that participates, as well as up to 3 public members who are really vital as they bring the voice of the patient and perspective of the patient to our work. We meet 5 times a year, and in addition to reviewing adverse events, which are required to be reported mandatory in our state and are very clearly defined. We also were the de facto group to examine workplace violence events, which unfortunately have increased dramatically. This will change with the passage of Senate Bill 459 in 2022. Workplace violence events will be reported to the New Hampshire Healthcare Workplace Safety Commission. And on July 1st of 2023, our commission was renamed to include the patient in it to prevent confusion. So we are officially New Hampshire Healthcare Quality and Patient Safety Commission now. So there's 4 guiding principles that the commission incorporates into their work. The first is promoting high reliability. Very critical to ensure that processes are standardized and that we have proactive mechanisms to look at potential error before they occur. We establish just cultures in our organizations. Unfortunately, errors will occur, and it's critical that individuals, while held accountable, are able to feel safe as those events are reported, investigated, and that we take a systems approach to investigation. We adopt evidence-based best practices to improve outcomes. So we really are looking at science in developing our processes and care recommendations. And we're ensuring that health equity diversity and inclusion are forefront. We understand, and this is where, again, incorporating the voice of the patient is critical, that in COVID only emphasized the fact that there are significant health disparities, unfortunately, in healthcare, and we need to address those as we go forward.
I have a question at this juncture. As part-time CEO of a small medical counseling and massage center in Kingston, is a facility like ours or a larger medical facility mandatory reporters if there's an incident?
So
I'm not asking for it, please. I wondered if there were.
Right, so there's mandatory adverse event reporting for various entities as a private practice, is if I'm understanding
Yeah.
it correctly?
Yes.
You would not have mandatory reporting.
Okay, you're talking larger hospitals and other public facilities.
That is correct.
Thank you. Please continue.
You're welcome. At this point, I'm going to turn to Rory for some highlights.
So for 2022-23, we had continued a lot of our virtual meetings that we had transitioned to during COVID. However, we had some concerns as the executive committee met that there was not the same level of relationship and interaction that we had had previously. So we have made the decision to move our commission meetings back to an in-person with a remote option for extenuating circumstances only. The attendance at all of our meetings was very high throughout this year, with about 35 to 40 members present at each meeting. At each commission meeting, we did do a review and discussion of the most recent adverse events data, which DHHS has provided for us, and that's been very helpful for the commission to have a more real-time view of what's happening across the state. We have seen, similar to national trends, that New Hampshire had an increase in the number of adverse events reported as the pandemic slowly began to unwind. And through the commission's work, we identified some workforce shortages as a major contributor to those that rise in adverse events. We had kind of the perfect storm of high vacancy rates, and then the unprecedented use of contracted staff, which we refer to often as travelers, which could be nursing, locum providers, other clinicians that come in. We had some new clinical leaders who may have been inexperienced as leadership that often got pulled into staffing roles as well, and were unable to mentor some of the new clinicians that were coming through. Many of those new clinicians that were coming through were educated during COVID, so their education looked very different than what we had experienced ourselves coming into the field, with a lot of person-to-person connection. A lot of these new staff were coming in with more remote or virtual experiences in patient care. So recognizing the challenges of the healthcare environment, our commission has been focusing on best practices to proactively identify some of the process failures, identify evidence-based tools to assist clinicians in hardwiring all the necessary elements for patient care. There was a bit of a back to basics theme in the past couple of years in unfortunately seeing some of our trends that had been declining going back up. So some of the topics that we've discussed over the past year in terms of quality and safety, we had some representatives from the Veterans Administration of Manchester come and speak about the healthcare failure mode and effects analysis framework to, again, proactively identify risks in new processes, do risk assessments, identify potential failure points, remove system vulnerabilities before the error occurs. We also had education on evidence-based team steps program, which is a nationally recognized program to improve communication and teamwork among healthcare workers to optimize those outcomes for our patients. And the speaker that we had was great in terms of providing us some real things that we could do right away. It wasn't necessarily conduct a bunch of meetings and get it off the ground, but there are things that we can do right now to change the way we communicate and improve that. We had some presentations on new models and strategies to reduce patient falls and reduce hospital-acquired pressure injuries, which continue to be the most commonly reported adverse events in this state. We had some storytelling opportunities, which are often very powerful, related to surgical adverse events, to identify commonalities and nuances in those events that we have seen. We included a review of updated guidelines from the Association of Operating Room Nurses, or AORN, on the use of technology to ensure accurate surgical counts and prevent retained foreign objects during surgery. And we did do a deep dive into some one-off adverse events. We have the commonly reported falls and hospital-acquired pressure injuries, but we did see some adverse events that we don't typically see. So we wanted to talk about what was going on with those, what we were seeing. We have seen a surprising increasing trend of sexual assaults that are reported. So by sharing the details of these events and the analyses and improvement opportunities, our members were able to share some valuable insights and tools to assist colleagues in preventing some of these similar events from happening in their own organizations. And again, moving into that proactive prevention. For patient and family engagement, we had a member presentation from a hospital that obtains real-time feedback from their patients through a volunteer rounding program where volunteers will actually go and talk to the patients while they are in the hospital and solicit feedback from them. Oftentimes we're relying on surveys that occur weeks or months after the patient has left the facility, where their memories may be a little bit not skewed or just affected by the time. But getting that real-time feedback, the volunteers were able to make some real-time improvements in the care and share some feedback with the staff. They gave some examples of their service recovery and the care improvements, and that was very powerful. We were educated on a new model called experience-based co-design to engage two groups in information gathering and partnering for problem identification and problem solving. From this, we learned some new ways that we could engage our patients and staff to work together on improving care for patients with, for example, substance use disorder. It might not be something where you want to pull a team in together, but to be able to interview them separately, get their experiences and bring those together. This process has also been used to improve the check-in process and physician practices, increase patient mobility during hospitalization. So a great new way to get us thinking and involving the patient in our process improvements. We've been very fortunate to have Dr. Ben Chan as a regular guest at actually a member of our commission. So he gives us.
He's looking for things to do until the next one hits.
Well, we've been keeping him busy, so he provides us every meeting an update on public health, which thankfully we are still continuing to talk about COVID-19, but we're moving into other things that are affecting the health of the state, including emerging infection trends, and the members have that opportunity to speak with him directly, ask questions about what's coming down the pike. We can share our challenges and provide suggestions on how public health can better support our work. So that's been a really valuable aspect of our meetings. So we've acknowledged that supporting that healthcare workforce, as I mentioned earlier, has been critical in rebuilding our quality and safety programs in our organizations. We've made it a priority to share strategies on how to do that, and that is ongoing. We've talked about developing roles for non-traditional members to incorporate into the healthcare team. How can we leverage artificial intelligence technology to aid our clinicians? The crucial role of visitors and volunteers, some of those people that we unfortunately lost during the pandemic when we shut our doors to both visitors and volunteers. We're now bringing them back and really embracing what they can do to assist us in our efforts, and creating that culture of continuous improvement through ongoing data collection, transparency, and accountability. So as we enter our 19th year, we had our first meeting in August. We remain grateful to the legislature for this unique organization. A lot of us, at least I do myself, refer to it as my own peer support network, having people across the state who are in similar positions to myself to share some of our challenges, some of our celebrations, and really take advantage of that network.
We're going to be needing to move to questions in just a minute or two, so if you want to wrap up.
That was the end.
You are good. When someone in one of the public facilities, the facility being a mandatory reporter, do things have to channel through the individual of that facility whose job is, among other things, to report? Or can anybody report? I'm looking at whistleblower if they perceive reporting was not done that should have been. How has that happened? Or maybe it's never come up.
I don't know if you have experience with that.
Well, there's a formal process for the hospital to report an adverse event, and I know there's some folks in the room that actually patients can call and do call directly to Department of Health and Human Services if there is a healthcare concern. They report concerns sometimes to the New Hampshire Hospital Association, who then takes that information back to the originating organization. So
An individual organization may have reported it, but not everybody involved may know that. So there may be somebody saying, I don't know what's going on, but I'd like them to, and they discover, oh, it's already underway.
that could be, that's a possibility for sure.
Because you now have the word patient in your title, so it sounds like it's possible that a patient may directly report.
So I've certainly had that situation where DHHS has called me and said we have received a concern from a patient or from a patient's family member. Quite often, we do have 15 business days in order to report that, and oftentimes we're within that 15-day window. And yes, I'm already aware of it. I'm submitting it to you. So we have those conversations with DHHS, but certainly if they shared something with us that we were not aware of, we would then go and investigate that.
The patient would not know of your specific organization or how to contact it, but they would probably assume DHHS sounds like a good place to go.
Yes, well, we have that on all of our websites on how patients can report their concerns.
Sounds like it's working. Yeah. Any other questions, Representative Murphy?
Thank you, Mr. Chair, and thank you for your report. The sentinel events on page 9, that chart really was flatlined for about a decade. And then obviously it spiked in COVID. Does your real-time data currently show it has gone down in the past year or so, or are we still at a fairly high level? And, go ahead.
So, no, it has not gone down. So
Okay.
we have 2 quarters worth of data for 2023 that we're currently analyzing in the Quality Commission. And our pressure injuries continue to rise, which is very concerning. And we're going to take a deep dive on that on our October 6th meeting. And our other ones are holding stable, but the pressure injuries is an area that we're concerned about.
Thank you. And the follow-up? Okay.
Follow-up.
And so you alluded to this, so I'm trying to think about the root cause, and I'm sure you're looking at it. Was it specifically, you think, the number, the actual physical number of care providers that were present to take care of the surge? Or was it the skill set that was the problem in taking care of the surge? And if so, are some of the thoughts going forward a change in the models of care that, you mentioned visitors and volunteers and working up to your license, your skill level and stuff like that. So where is the focus? Is it hiring more people, or is it basically, are we going to be looking at a different care model going forward, you think?
I would say yes, both.
Okay.
The first key is actually getting people to fill our vacancies. And that's, I think, a priority. But then once those people are on board, we need to look at how we're providing that care. Is there a way that we can do it more effectively, more efficiently, and give them the tools to care for our patients?
Follow-up?
And
Yeah.
just the last follow-up,
That's quite
I guess, at DH, the biggest problem right now is housing. You just can't find anybody. Is that the major problem that you see as far as hiring people, or is it pay levels, or how can legislation in any way help you to improve the vacancies that you have?
So housing definitely is an issue. And I know many hospitals have gotten very creative in trying to find and make housing available for staff. The stress of the workplace is very high. It's a very high stress environment. There's high levels of burnout, unfortunately, with our clinicians and our providers. So anything that we can do, we're very excited about the new Workplace Safety Commission, as we feel that's really going to bring a lot of attention and focus to that issue and solution. So anything that we can do to support that, because we need to make these workplaces a safe place and a place where people want to be. And unfortunately, that's been a very difficult environment.
And I would say that we are seeing some stabilization in terms of at least in my own organization where I work, we've had a lot of people who were contract staff, travel staff, who are now flipping to permanent. They're choosing to stay. So I think the appeal of travel has worn off a little bit, and we're also approaching how we're bringing on new staff and providing them a high quality orientation to what we do and how we do it.
In terms of your burnout, one of the things I've instituted in the organization I'm part-time CEO of is PTSD debriefing. I watch my staff. I see not only the circumstances that may make it possible for this to happen, but also indicators in the individual, suggesting this to another branch of our government as something they would implement. One cause of burnout is the need for review with people who have been the professional in a series of adverse circumstances. Are you doing anything like that now? And will you, if not, will you start it on Monday?
Well, what I can tell you, and I'm really proud of this, is for the past 6 months, we've convened our New Hampshire hospitals in a clinical peer support learning collaborative. And we, for the sole purpose of talking about, not just in an adverse event, it is critical in an adverse event that we support our clinicians, and we're talking providers plus, certainly nurses and others who need this support, but just in times of high stress. So what can we do to develop those programs within our institutions? What training do people need to be clinical peer supporters? So there's been a real uptick in momentum on that. And we're at the point of increasing training now so that hospitals can develop those programs formally and informally.
I'm familiar with how the fire service does this and has done this for years and very well. But could you shoot me a memo some point on how you're developing it, because it will help in the particular group that I am hoping to initiate this with.
Absolutely, be
Thank
happy
you.
to.
Any further questions, Representative Palmer?
Thank you. My question is coming from having been on peer review for years, and the work that obviously you've been doing is like where we've all wanted to head, both from the point of view of not just blaming people for things, but also enabling patients and the custodian to be able to bring things forward. One of the things we've been talking about recently is the fact that the rate of change of various things in working in an institution really gets ahead, and so there's always a new thing that you're having to learn. And what I find now is, maybe it's because I'm getting old, is that I'll be thinking I should be learning something more about the actual job I do, but now I'm going to learn something more about fire extinguishers or a new system for doing something related to the EMR. And do you look at that kind of issue as something that needs to be looked at? In other words, it's great to come up with a new program that's going to work better than the last one, but it's a new program and now everybody has to adapt to it. And how does that affect the job?
I would say, I think we've all experienced that. I don't know that we've talked about that specifically as a group, but I think that that's a great point to bring forward, that we're aware that we just add and add and add, but looking at when you add it all together, what your actual job is and the time that we have to do it, I think that contributes to the level of burnout, overwhelm, and the challenges in getting our jobs done. So I think that that's something we can certainly bring back to the commission as a discussion point. So thank you.
Anyone else? Before you leave, Representative Edwards and I have decided to learn BSL, which is Bureau Speak as a second language. And having tracked you today, all you missed were insularity, granular, and intersectionalism. You hit every one. And I'm learning. So thank you. And thank you for your presentation as well.
Thank you. Thank you.
And before I call the next group up, and this should be please in the minutes, it is not the responsibility of an individual member to get his or her replacement. That is not that person's job. It goes first to me and then to the Speaker's office, who then makes the appointment. And secondly, do not, if you're not going to be here, do not inform me at 10 o'clock in the morning of the meeting. Several people here are not here A few informed me of that. Representative Edwards is laid up from foot surgery. Representative McDonald called me. Others did not. And I've been working the phones, as you have seen, to try to do that. So please, if you can't be here, let me know as soon as you know that. I have 2 alternates, but when I've got the alternates into the full-time slot and I still don't have a quorum, I have to do a lot of work in real time. So just for the minutes and going forward. Thank you. Next, adverse events annual report. And I'm going to guess this is Doreen Shockley and Lizette Wiesett. How am I doing? Did I go? Yeah, it's right here in the text too.
Good morning. My name is Lizette Wiesett, Supervisor at Health Facilities Administration Certification Unit.
Good morning. My name is Doreen Shockley. I am the manager at the Bureau of Licensing and Certification at the department, and we're happy to report to you today.
So I'm here to present the 2022 adverse event reports. So first and foremost, it is important to remember that consumers should not compare the quality of care and safety of the facilities by the number of types of adverse events reported. Consumers need to look at all factors such as the size of the facility, scope and complexity of services offered, the number of services performed at the facilities as well. New Hampshire hospitals continue to face challenges during this COVID-19 endemic. You've heard from the previous presentation. For our adverse events report, we utilize the National Quality Forum adverse event list as a basis for the state mandatory adverse event reporting system. There has not been any recent updates to that guidelines. And in 2022, we have seen an increase of adverse events reported compared to previous years, with a total of 118 adverse events reported for 2022. I did have a report. I just want to make sure great.
Before you move on, you are seeing an increase in adverse reports. Is that because there are more adverse reports or better reporting?
At this time, it's more adverse events report. Let's see. There's top 3 adverse event categories that was reported, that continues to be reported, which is surgical events, care events related to pressure injuries, and care events related to falls. So pressure injuries were a total of 41 this year, which is found on page 6. Falls were 40, which is found on page 7, and surgical events are 14, which is found on page 8. Considering that these event types represent about 81% of the total reportable events, we continue to focus our efforts on these and address what the New Hampshire Hospital and ambulatory surgical centers are doing in these areas to improve, which is found on page 6 to 9. Our department does conduct 10% sample audits quarterly for the 2022 calendar year, and adverse event reports selected were in random for this audit. Taking into consideration, the sample would include the most reported adverse events and the least reported adverse events, and our department concluded that the New Hampshire hospitals and ambulatory surgical centers followed through with their corrective action plans to address and correct the problems identified through their root cause analysis reports. That's pretty much. Do you have any questions?
Anybody thus far? Any questions thus far? Representative Murphy.
Thank you. I was reading the report, and just a simple question, I believe. Why is it that New Hampshire Hospital is not required to report the adverse events? Why are they accepted out?
The New Hampshire.
Except it says, all have to report serious, except for New Hampshire Hospital.
So I will confirm that, but our law exempts state-owned and operated facilities from a lot of the requirements and regulations. And I think we don't do inspections at state-owned That might be because we're also state employees and that's a conflict. They have accrediting agencies that do the work that we do. But I will confirm that. That's my guess.
And Paula Minahan from the Hospital Association, who I've not yet been able to get to speak today, nodded
Okay,
affirmatively.
that's correct. Thank you, Paula.
Good.
So that's why Hampstead Hospital does report, but New Hampshire Hospital does not?
Well, Hampstead historically has, but Hampstead going forward will not.
Will not. Okay, thank you.
Anyone else questions thus far in the report? And seeing none, please continue.
I'm actually done.
Okay. I mean, you want to save 5 minutes for next time you come? Because you're really short here.
Yes, last time we actually used an additional 10 minutes.
right.
Remember? Okay,
No,
so we're even now.
No, I don't. But thank you.
Thank you.
Any other questions? Yes, Representative Murphy to the rescue. Thank you.
Thank you. The number of total was 118. Is that up because of COVID, or is that up actually as a number relative to where we were in 2019? And the reason I asked that question, 80 out of the 118 are really bedside in a sense, care problems. And is that just related to staffing and the inability to take care of, roll a patient, get a patient out of bed safely, that sort of thing?
Yes, it's definitely, staffing challenges has definitely affected patient care. And that's why you see, the increase of the pressure injuries, the increase of the falls. And if you really look at the numbers, it's really more bedside. With the travelers, consistency is definitely, kind of a problem. And even right now, it's kind of we're still trying to, New Hampshire Hospitals is trying to kind of still recover and work on a better consistency with their staffing so they can provide more consistent patient care. And we do see a lot of sicker patients. That means the hospitalizations are prolonged, so they're in the hospitals more, and their risk of getting this pressure injuries and risk for their falls has increased as well. So.
Is there a mechanism whereby you look at the number of incidences in a certain category as a function of total patient census? Because if your census is high, you're going to have more. But if we don't know the census is high, that data may not tell us whether things have gotten worse or it's just there's more. So is there a way to analyze data in that
Yeah, we
function?
don't really track the census on the hospital. That's why when I mentioned earlier, when you look at my report, you have to also consider where the hospitals are, the scope severity that the services that they offer, the facility, how big the facility is. We really track that they're reporting adverse events, that they're actually doing their root cause analysis to address those concerns and come up with a corrective action plan. So I do work closely with the New Hampshire Hospital team commission, just to kind of make sure they're aware of this and this is the numbers are high and that they're at least working collaboratively to kind of work on looking at, what are the big issues, what are the things that they could do better, work on, or kind of find more better, newer interventions, I guess.
And Chair recognizes, please tell me your name. Come on up to a microphone near you. You can come up to the big people's table or the big people's table. Either one. See, the senator gets to pick them up.
I don't know if I should sit.
Yeah.
You need to have a microphone.
Okay, thank you. So Chris Herring, Vice President for Quality Improvement and at the Foundation for Healthy Communities and Administrator for the New Hampshire Healthcare Quality and Patient Safety Commission. Thank you so much, Chairman Pearson, for asking about census. And that was just something that I wanted this commission to understand, is that at the end of 2020 and through the first 3 quarters of 2021, hospital inpatient census was down significantly. If you can recall those dark days of COVID, we had stopped elective surgeries. There were patients that we expected influx. Obviously, those patients that were critically ill were in the hospital. Otherwise, patients were staying away. And a lot of them deferred health care during that time. So while our adverse events during those years, that period of time are down, our inpatient days were down significantly. In the end of 2021 and throughout 2022, the exact opposite. Inpatient days at an all-time high, hospital capacity at approximately 98%, hospitals at capacity or above capacity in many instances. So patient days higher, adverse events also have been higher.
So if there could be some mechanism, it could be data for those scientifically minded or narrative for liberal arts kids like me, it would avoid the shock. I don't mind the shock, but I do mind the shock, of value of seeing a spike in numbers without a narrative explaining what is going wrong with our hospitals. Nothing. More beds are filled. That would be helpful in some way of reporting going forward.
Thank you.
Because I want to make you guys look as good as you are.
Thank you. And there are mechanisms in some places where we report, for example, there's NDNQI, it's a national database for nursing quality indicators. And in reporting those nursing quality measures, there is a denominator that includes patient days or a number of encounters or whatnot, so that you can do that comparison. But we don't have that. But thank you for that recommendation.
You're welcome. Thank you for your report. And before we come to the next people to come up, again, adding to the notes, back under Alzheimer's, the chair appoints the Honorable Dr. Jeff Soloway as an adjunct member to the Alzheimer's group. He had served in Health and Human Services and Elderly Affairs Committee for 6 years. He had served on this committee for 2 years. He's an epidemiologist by training. And when we were chatting about something totally unrelated, he said, could I be in some way on that committee? And I said, I'm going to have to find out what the some way is, but I have the authority to add him. I've already discussed it with Jessica Escalin, who is soon to be talking with newly elected Chairman Senator Avard, that Dr. Soloway will be present and speaking. We seldom vote in these things, so he'll be an adjunct member. I also wish to thank, before I forget it, Christina Daya for filling in for I keep doing that to him and it's not nice. Counselor John Williams, that's the guy. Thank you for filling in so much, appreciate that. Chair recognizes now Michelle Roberge and Whitney Hammond. And this is for a review of something.
Does that mean that's on? Yes. Good afternoon.
Not yet. We're on
time. So I'm Whitney Hammond. I'm the acting bureau chief for the Bureau of Prevention and Wellness in the Division of Public Health Services in the Department of Health and Human Services.
Good morning, Representative Pearson and members of the committee. My name is Michelle Roberge. I'm the Bureau Chief for Public Health Protection within the DHHS.
Still working on the French accent, aren't you?
Yeah. So with me today is Whitney, and Whitney will be the one that'll be discussing this item with you this morning.
So hopefully everybody has copies of the letter that we submitted. So I'll go over what's in there. So pursuant to HB 2, Chapter 79, 429-2, Laws of 2023, funding was appropriated for the department to conduct the third phase of our community response to cancer concerns in Merrimack, New Hampshire. Pursuant to HB 2, Chapter 79, 429-2, we were to come before this committee prior to using that appropriation for review. That appropriation included $500,000 to be used in this state biennium, which ends June 30th, 2025, to be able to contract with an academic or research organization who would be able to conduct what we call a feasibility study, which is really focused on determining if there would be potential to actually apply for and get funding for a full epidemiological study looking at kidney cancers and environmental exposures in Merrimack. Pursuant to HB2 language, the department was asked to identify if there was any other funding, federal funding, grant funding, non-state funds that might be available to support that feasibility study. So the department has done their due diligence in looking for that funding. We routinely and systematically monitor for federal grant funding. We work closely with our federal agencies who provide funding. So the Centers for Disease Control and Prevention is one of our primary federal funders. And we are not aware of any funding that would support this feasibility study. And for a little bit of extra context, a lot of the funding that we get is to support public health response and the work of the public health agencies. And this stage of the, community response that includes a feasibility study really represents a step further than public health response and more research work. And so there aren't typically research grants that the department applies for. We have worked with academic partners to see if there are grant funding opportunities that might be available for them to apply for, and have also not identified any funding. Any questions?
Does anyone have a question thus far? Seeing none, you may continue.
Okay. I think that's pretty much it. We just wanted to thank Representative Nancy Murphy, Representative Erica Leon, and Representative Maureen Mooney, who have been so helpful in getting this appropriation and enabling the department to continue our response to the concerns in Merrimack. So thank you.
Good. Well, that's it. Unless anybody in the committee has anything, I would like to see Associate Commissioner Henn up here at the end, please. Then we are done with 20 minutes to spare. Wow. No, I mean up here, not up there here.